Hello. So for job number 4, I interviewed with the doctor. It was a very, very busy practice. I was nervous because he knew the doctor from job number 2, where I resigned with the contract. So I was nervous that or whatever she might have been telling him, it might have not been good for me as far as me quitting the job before the time was up. So I didn't think he would hire me. But 2 weeks later, I started the job. Um, I was trained for about 4 hours. It was another MP in there that kind of started maybe, I don't know, 6 months prior or 7 months prior, something like that. Yeah, 7 months prior. So she was training me, kind of giving me the rundown. She was still new, a new MP, so she was still trying to learn herself and how it is that she should practice and what is it that she should be doing and how to manage primary care. But she was familiar with what it is that needed to be done in the office as far as the sleep studies, the managing the CPAPs, and managing the inhalers. It was a pulmonary office, so she was pretty good at that. So after 4 hours, it was requested by the doctor that I try to see patients on my own. So I did. I struggled a lot with managing like the CPAPs and the sleep studies. It was very technical. That was new. So you had to upload, the patient would come in with like a little disc. You had to upload it to the computer. It would give you the report of if they're using their CPAP or not, if the CPAP is working for them or not. Like it had a whole rundown. So, that was new and it was technical. Um, the practice consisted of two medical offices, one nursing home, and two hospitals. The office he shared with the wife, who's a cardiologist. So sometimes we were all, like on Fridays, we would be in the office together, seeing patients. One seeing cardio, the other seeing pulmonary. And so most of the time it was mixed in between. They intertwined together. Uh, the nursing home, I'll start with the nursing home. I was familiar with the nursing home from the first two jobs that I had. So it didn't make me a difference rounding in the nursing home or not. This particular nursing home, I was familiar because the job where I had the contract, that doctor also went there as well. So I was very familiar with this nursing home, just new patients for me. But ultimately, this nursing home was an absolute nightmare. When I worked with the other doctor, she's strict. She doesn't play any games. She doesn't tolerate any nonsense. A lot of people are scared of her. But this doctor that I worked for currently, he didn't let things bother him too much and kind of allowed a lot of things to slip under the rug, right or wrong. But he was really busy as well. Like, he had a lot of patients in the office. He had the nursing home to manage and two hospitals, so he was really busy. Um, in the nursing home, primarily it was ran by LPNs. This particular nursing home, only LPNs. Like they're in supervisor roles, they're in management roles, and they had no assessment skills. In this particular facility, I'm not talking about LPNs. I'm just talking about this particular facility where the LPNs, they didn't have any assessment skills. They wouldn't even report abnormal labs to you. So patient management was horrible on their part. It made my job really hard as an MP. Sometimes my orders wouldn't be carried out. I would order something, whether it's a stat lab, because maybe this patient uh, doesn't look too good. Maybe they're not breathing as, like, their oxygen saturation isn't what I may want it to be, or maybe they had a fever, and I just wanted to order labs to see what's going on. You would come in the next day and it wasn't even done, and nobody seems to know why, and no one seems to care. So there was never any consequences for it. Yeah, I would report it to like the director, who, they were RNs. They didn't seem to care about much either. But I would report it. Nothing much would get done. There was no consequences. And the doctor I worked for didn't seem to be too bothered by this as well. Um, Leadership for that nursing home, they didn't want you sending anybody to the emergency room. They wanted you to manage it first at the nursing home. And this would be fine, but except what I just talked about with you, the fact that if I order labs, sometimes a lot of my orders are not even carried out. So if I'm having something emergent going on, I'm not going to leave the patient here for you to manage. Absolutely not. So like, for example, I had a patient with chest pain. I think she had started having chest pain over the weekend on a Saturday. Now it's Monday that I'm seeing the patient. And I come in and the patient tells me she's having chest pain. I want to send the patient straight to the emergency room because, first of all, if I order stat labs, it's not going to get done till tomorrow, maybe the following day. I need a stat troponin, I need stat chest x-ray, I need stat EKG. Not going to happen, ever. You know, I've learned all my lessons with ordering things stat with them. You leave the nursing home and expect them to call you and expect you to manage these things, and they don't. So no, I'm not going to leave my chest pain patient there any longer. You should have called already. So I put in an order for the patient to go to the emergency room. And the nursing director gave me a call, like paged me overhead. You can hear the urgency in her voice. And so I'm already annoyed. I answered, I called the extension back and she's like, why are you sending this patient to the hospital? I said, because patient is having chest pain. And she's like, well, she's been having chest pain since Saturday. And I said, and you don't see a problem with this? Is something wrong? Is something wrong here? First of all, I don't need to ask your permission to send the patient anywhere. Last time I checked, I have a license to practice and I was taught most of the things that I need to do. And I am sending the patient to the emergency room. You can't even negate it, you know? Your license doesn't supersede mine. I am sending my patient to the hospital and that's where she's going. You know, so the nursing home kind of got a feel for like, okay, here comes Cheryl, you know. She doesn't play around or she's going to be having us do things we're supposed to do type of thing. You could see the looks all over their face, but I didn't care because I was there to take care of the patients. That was my job. I actually enjoyed doing that. If that was my grandma, my grandfather, or my family member, I would want someone to take care of them the correct way. I didn't care what anybody thought. You know, I'm there to do my job and I'm there to do it efficiently. So there were so many situations that happen in that sense. You know, if I have a patient whose blood pressure is running low, you look at the labs and, you know, their white blood cells are a little high, or you get a chest x-ray back and they have pneumonia. It's like, okay, I want to start this patient on antibiotics immediately and I want to get some fluids going. So we need to insert an IV. So later on that day, mind you, because things take a little longer, it's not an acute facility. So you have to understand things may not happen like this, like it may happen in the hospital. So, you know, in the morning I ordered these things. By afternoon, you're calling me, telling me you can't insert the IV. In my mind, this should have been done already. So, you know, they're having trouble getting the IV. Okay, what do you want me to say? Okay, let's not give antibiotics. Let's not give fluid. Let's just forget about it. No. What are our options? You either one, insert the IV. Let's get the fluids going. Let's get the antibiotics going that I ordered. Number two, you can call an outside agency to come insert a midline or get someone that can insert the IV. Or three, we can send the patient to the emergency room. My favorite thing to do for that nursing home. Send them to the emergency room so they can be effectively managed. So there was just so many situations like this. The thing about this nursing home is like they wanted to kind of call you and put the onus on you, like, okay, well, I told the nurse practitioner, but I don't really want to do anything about it, you know? So in the beginning, like they were giving your cell phone number to call you with any issues or text you. Not even text you, they should call you. But even if they text you, you know, they should make sure you got the message. They should get a response. That's not what they were doing. I could be home and I can get a message. I could be sleeping or whatever. I'm off of work. I can get a message from them. Something urgent is going on. They don't care if they heard from me. They don't care if I'm getting back to them. They just want to dump it on you so that they can write in their note, report it to the NP. No, I don't think so. So what I did was, first of all, I changed my phone number. Y'all can't call me. You got to be smart in order to call my phone and to text my phone. You got to have skills, because I'm not going to fool around with that. So the first thing I did was change my phone number. Next thing I did, I typed up a letter. I talked to the doctor. So, we got to get one way for them to be able to communicate with our team. One way. So he came up with the emergency email system. They can immediately, and it comes right to our phone. It was set up on our phone. It was almost like getting a text message, So we let them know not to call any providers' personal phone numbers. You use this number only. As the new way of reporting urgent needs or whatever you need. You send it to that email. You're not calling my personal phone, because I'm not going to answer you, and I'm not going to respond. You have no permission to use my phone. And in that way too, the doctor's getting the message as well, and he's responsible for handling that when I'm off of work. So I did set that up. When I first started going to the nursing home, mind you, when I worked for the previous doctor, she was really strict. So my notes had to be good. She taught me how to order labs. I had to order labs. That's something I learned, and I learned it well. She was a hematologist, so I better know how to order labs. So when I went to the nursing home and you look through all the patients' charts, first of all, the way their progress notes were written, it was, I can't explain it. It wasn't an effective progress note. You didn't even know what was going on. You didn't even know what to follow. It's almost just like taking a stamp every day and stamping the computer just to say you've seen the patient, but what did you really do for the patient? What is the patient's diagnosis? I couldn't figure any of that out from whatever system or whatever progress note each nurse practitioner that went there was following. So when I started rounding there, first of all, no labs. They were just ordering PT, PTT for no reason. Why are you ordering that? What is that? What does it mean? Where's the CBC? Where's the basic metabolic panel? When our patients come in from the outside, where's our lipid panel? Where's our hemoglobin A1C? These are basic labs you need to get. If my patient is anemic, you need to do an anemia workup, ferritin, TIBC, the iron profile, B12, folate, stool of coal. If you think they're having to bleed, do the TSH level. This is all part of the anemia workup. None of that was being done. So a lot of times if a patient is coming in with a hemoglobin of 8.2, maybe now's that time to start doing an anemia workup, because you can get to the problem. If they're iron deficient, you can start iron. If it's B12, start the B12. If they have a GI bleed, well, let's get them to see the GI doctor. So I remember a patient's hemoglobin was 7.1, and it was merely just an issue of needing iron. But at this point, we have to transfuse because the hemoglobin was, I think it had dropped to 6.9 or something like that. So, you have to give a blood transfusion. But all because we didn't do an anemia workup and get her the iron that she needed. So little things like that was going on. But it's not that I'm judging or being judgmental, because everybody was new. That was going to that nursing home. I probably was coming in with more experience than most NPs would come into the job with. So who was teaching them? You're just sent to the nursing home to kind of round on your own and figure it out on your own. But who's teaching you? Nobody. Nobody's teaching you how to write a note. No one's teaching you how to order labs. The doctor just sends you there for you to figure it all out on your own. And that's what they did. So I changed the way I changed all the format of every note. Every patient I saw, I changed the format of the note. I developed a plan. And I remember the NP that was working there, she was off that day. She must have been home following my notes. And the next day she came in and she's like, wow, I like the way you write your notes. That makes sense. I know what's going on with the patients. I can follow that. And then you can actually learn. So, I was kind of intrigued with that. That was interesting. But, she was a new NP, and then she's just teaching herself. So it's fair. Not that I knew everything, because I was still learning as well. But and I would ask her questions too, because she was practicing. She was doing pulmonary and she was working in the hospital. So it's a lot that I didn't know too, as far as the practice. So as I was saying, the doctor, he didn't seem to care much. He never came to round in the nursing home. To me, he could care less. Um, he's a very nice doctor, very knowledgeable, but I just think that he was way too busy. He had a lot on his plate for the whole day, and that nursing home was a pain. If if he can throw it on to someone that he's paying to work for him, then that's what he's gonna do. He wanted nothing to do with that nursing home. To be honest with you, you could tell he didn't say it, but he wanted nothing to do with that place. So I would go to the nursing home on Mondays. I would round in there. I would get a whole day to see patients. It could be up to about 50, 60 patients in the nursing home. Long-term, subacute, I don't know, maybe 10, 11 maybe subacute patients. So you have to see them 3 times a week. The long-term once a month. But remember, like the long-term patients, just like if you get sick, you go to your doctors, they have that as well. Like, maybe they have to be seen more than once that month. Maybe this long-term patient has pneumonia. Now I have to see this patient 3 times a week too, or more, or every day, just to make sure they're getting better. So it depends on what's going on. But Mondays we were given the whole day to take care of the nursing home. They had the way they had it set up. They were seeing all the patients every day, and I'm like, no, that's what makes the job hard. I'm gonna see the patients based on state guidelines. I'm going to see the long-term patients once a month. I'm going to see the subacute patients 3 times a week. I'm not going to be trying to stress myself out, because once I'm done with the nursing home starting Tuesday, you have to go to the office and start seeing all those office patients, and then everything else is out the door. The office is very busy. And in between, you have to check the labs at the office. You have to check the diagnostic studies at the office. You have to answer emails. You have to, I call it bullying. The patients are bullying you to hurry up and fill out their paperwork to get like discounts on their electric bill, or write notes for work, it's always something that you had to do. Social work, I call it. It was a lot of that going on that you had to address in between seeing patients. And you didn't have any time set aside to necessarily perform these tasks. You had to do it. You had to find time to do it while you were seeing patients. Okay, let me take 2 seconds to check this lab. Let me take another 2 seconds to check this diagnostic study. Okay, I'm gonna see a patient. I'll see 3 patients, and then after that, I'll try to check some more labs. So it was almost impossible. And mind you, you might be still working on the things that you were doing from the nursing home, trying to follow up on labs, trying to manage this, trying to manage that. So it would become impossible sometimes. Now, every other week, because we all hated going to the nursing home. We hated it. So we'd rather be in the hospital, period. The thing is, when you go to the hospital, that's all you do for the day. So it's sort of nice. So every other week we took turns, me and the one in MP, we took turns going to the hospital. 1 week I was in a nursing home, and then the next week I was in the hospital. But the problem was that you never really had consistency, right? So, you're just kind of back and forth. You don't have time to like really learn one thing. And what I'd rather be learning is the hospital. I like acute care. That's where you're really going to learn. I'm not going to learn nothing in a nursing home, fighting with the LPNs to report potassium levels to me, or to carry out orders that I put in. I'm not going to learn nothing doing that. But going to the hospital, it's where I learned, and I'd rather have been there. So that's the nursing home. So let's talk about the office. The office was a hot mess, for a lack of better term. It was shared, the practice was shared with the wife. She's a cardiologist. The computer system, there was one computer system we used, so you didn't know what was going on. It's like cardiopulmonary, I don't know. You don't know what they did the last visit. It just didn't make sense. However the computer charting was, it was just a mixture of noodles in there. You're like, oh my God. So you ask the patient, what brings you in today? And it's like, you don't know why I'm here? No. And we'll never figure it out if you don't tell me either. Because you look at that computer, you log into their chart, nothing. It's just mumble jumble everywhere. You don't know what's going on, literally. So the goal of the office, hurry up and see the patient. No one cares. No one cares what you do or how you do it. Just get it done. and it should be right when you do figure out how to get it done. What you did in the office, you addressed pulmonary issues, CPAP issues, sleep studies, inhaler management, cough syrup management, that refill of that promethazine with codeine for no good reason. Cardio sneaks in here and there. You're like, oh, well, I'm not cardio, but okay. Writing notes for patients, discounts for their discounts on their electricity and things like that. Medication refills, checking the labs, checking the diagnostic studies, checking the emails. That was the basis of the office. So for the hospital, like I said, this was my favorite part of practicing as an NP, working in the hospital. I just felt that I can come in and I can kind of do my own thing. I see the patients, I go over the labs, I go over the diagnostic studies that they order for the day, and I'm managing the acute issues. No one's bothering me, not one soul. I'm just able to get my job done peacefully. The doctor, he would call you in the morning when you first got there to go over each patient to tell you what it is you needed to do. And then you really wouldn't hear from him. He might come in and round with you, he might not. And if you have a question, you can easily reach him. He will answer. So I enjoyed the hospital. But like I said, I didn't have consistency. I didn't have stability because I was just kind of getting jacked back and forth. So they had a new NP that started to come help us out. She was going to be working in, doing everything, hospital, nursing home, and office, just like us. And, it was hard for me because maybe I had the most experience there at this point from all the jobs that I had. And so everybody kind of depended on me to help them or teach them, or he would kind of have me train them in a way, tell them what to do and how to get going. But the thing is, I wasn't ready for any of that. I was in a situation where I needed to focus on myself, focus on my own growth. I still had a lot to learn. And so as busy as the practice was, I didn't have time for another NP to be depending on me to help her. Or at one point, I remember her calling me, asking me a question. I'm like, no, you need to call the doctor. I can only be responsible for my own practice at this point. I'm way too new to be trying to tell their NPs how to practice. That's not what I do. I don't want to do that. I have a lot of knowledge and I get a lot of the work done on my own every day, but the onus is on me. I don't want you to do something wrong and then everybody's looking like, oh, Cheryl told her to do that. No, you call the doctor. But, the NP was she was new and she was an ED nurse. And she came in and didn't know anything. I can't say she didn't know anything. You don't know how to manage things. It goes back to your new NP. You're trying to learn your role. So she had a bit of a hard time kind of understanding what we needed her to do, in a sense of, you can't go to the nursing home every day and stay there for 8 hours a day. That's not the job. Monday, you can do that, but Tuesday, Wednesday, Thursday, Friday, you got to get back to the office. You got to be able to see patients in the office and do all the things that's required. And after like 2 or 3 months, she just wasn't able to do that. She didn't even try to do it. And, a lot of these jobs, you have to be able to come in and adapt to what the job is requiring. Or don't take the job at all in the beginning, right? So it's not fair that the other NPs have to adapt to what the job's requiring, but then you have a new NP who doesn't plan on adapting to what we got going on, just not trying to do it, and then everything falls on you. Like, as the experienced NP, you're trying to do everything. You start getting overwhelmed. I think that once COVID started, it just kind of was starting to be the end for me, because that same NP decided to, it was a scary time. She decided to kind of leave the job. She had a chronic condition which she was scared to catch COVID. So it was just me there practicing. The other NP had already resigned prior to COVID starting, so there was no one but me as the NP to manage the nursing home, the office. The doctor was in the hospital managing that by himself. He was very busy. But my thing was, I can't manage the nursing home in the office. Like, they wanted me to do virtual visits for the nursing home at the office, but at the same time, I'm busy in the office still. I'm still seeing patients. I'm still doing virtual visits in the office. So it was so overwhelming. It was a really bad time for me. And again, I was responsible for everything, and I didn't want to be in that role. You know, I'm responsible for the nursing home because who else is taking care of them? You're the doctor, but you're expecting me to manage the nursing home by myself? I couldn't do it. It was way too much, way too overwhelming. And so in the office, fighting with people over there, promethazine with codeine, because I won't do it. I'm like, nah, you don't need it. I don't hear any, you don't have any pneumonia. I don't hear you haven't coughed once since you've been in this office. I'm not prescribing the promethazine with codeine. I don't want to. So, you don't need it, like I said. So, that was a big thing too. Like, just doing things just to make patients happy so that they can come back. I don't like practicing that way either. I like taking care of you because you need to be taken care of. If I feel like you need promethazine with codeine, I would be glad to give it to you. But I don't want to, I'm here for my refill on my cough syrup. No, you're not here for your refill because we don't refill cough syrup. I don't refill cough syrup. I don't like that practice. But then they only want to see the doctor because he's going to do it for them, So, that was something that I had to deal with too. I didn't like it at all. Fine, go to the doctor and let him do it. But during that time of COVID, the doctor wasn't coming to the office. How could he? He was very busy in the hospital. So his regular patients that would normally see him had to deal with me. And, it became a fight. Like, no, I don't need to give you your cough syrup. And then they're calling every day, harassing you as if you have to do that. No, I don't need to. There was no indication for me to prescribe this to you, and I don't need to do it. So it was so many situations like that, on top of COVID, on top of the nursing home, on top of working on your own, on top of being short-staffed because people are getting sick. It was just way too much for me, and I was going to try to stay at this job for about a year or two. And I just kind of decided, like, you know what? I'm just going to go ahead and give a notice and resign. Let them know that after COVID is over, I'm going to be resigning. So that's sort of what I did. Now, mind you, I had already been working a per diem job in another hospital. I was working there like once a month on the weekends. We'll talk about that job next. But I was only working per diem, and that was my ultimate goal, to just work for a hospital, period, just one job. So I was going to eventually transition into just working for that hospital. I was per diem. But since I just was unhappy working at this current job, I decided to resign sooner. I think I was working there for 8-9 months at this time, and I put in my notice. And it was kind of sad because I really, really liked that doctor. Ultimately, he was a nice person. I just didn't like that practice either. I think the whole thing boiled down to, I don't like private practice. I don't want to have a million things to do in one day. It's just not for me, and I'll never get another job that has so many tasks to do for the day. I don't want to work like that. It's not for me. It's not working out. I'm going to always resign. So I've come to the conclusion that I don't want to work any private practice ever again. And I won't work unless it's in the hospital setting. So at least I've come to figure that out.